Welcome, and thank you for joining us for this presentation titled New Developments in Bipolar Spectrum Disorders in Children and Adolescents. This activity is based on a satellite symposium from the 30th Annual Psych Congress. The faculty members for this activity are Melissa Del Bello, Kiki Chang, and Adelaide Robb. Participants are reminded to review the learning objectives and faculty disclosures available on the accompanying webpage. This activity is supported by an educational grant from Synovian Pharmaceuticals. This activity is jointly provided by North American Center for Continuing Medical Education and CMEology.
I'm going to be talking to you for the next 25 minutes about diagnosing bipolar disorder in children and adolescents. And I find it very interesting because I have been giving this talk for the past 20 years. And 20 years ago, it was very controversial to diagnose bipolar disorder in kids. And in the 2000s, it became a very hot topic, I should say, with the publishing of a book called The Bipolar Child, as well as a lot of renewed interest from different research groups in this topic. And then it went from being a diagnosis that was underdiagnosed to a diagnosis that I feel was overdiagnosed. And now 20 years later, I think we've reached somewhere in the happy middle in which all controversies eventually lie, which is probably somewhere in the middle where we realize that this is actually not a rare disorder. It's a very common disorder, but it's also a disorder that bears very tight specificity in the diagnosis because there's a lot of other disorders that can present with things like irritability or temper tantrums or big outbursts, which is what it was being misdiagnosed with in the early 2000s. And so I feel like we're in a good place now that we can still recognize children with this disorder, but yet not overdiagnose it and treat them inappropriately. So, in my disclosures, I do consult with a couple companies, most recently Octapharma and Synovian. And my first slide deals with the fact that bipolar disorder in general in adults is a fairly common disorder. And studies have ranged from anywhere from 1% to 4%. But basically, when you combine the rates of bipolar 1 and 2 disorder in adults, it's somewhere around 2 to 4% of the population, which is very high. That means that 1 out of 25 adults may have a bipolar spectrum disorder. We know this that about half to two-thirds, actually, of adults with bipolar disorder had their first onset before age 18. And some people are very surprised by that. But the studies do bear that out. It's hard to do a long prospective study starting in childhood and following all the way up until adulthood. But with retrospective studies, inquiring patients when they first had their first mood episode, whether it's depression or mania, over half the respondents have responded in 3 different studies that it was during childhood or adolescence. And in fact, you can see from this study done at the NIMH, it was that 14% of the respondents said actually their first episode was before adolescence, so during childhood, which is a very high number when you think about how rare it was thought to have started before age 12 in the past. So we really look at bipolar disorder now as predominantly a disorder that does begin during childhood. Very often it's not recognized until later or recognized until late adolescence, and so we have to do a better job and a good job of identifying it early enough to catch it and treat it correctly. Why? Well, because it is potentially this common, we realize that it carries a lot of morbidity, and it is probably, not probably, it definitely is worse to have the onset during childhood compared to during adulthood. You have higher rates of school failures, you have higher comorbidities, higher suicide rates. So it's a more severe disorder the earlier the onset, which makes sense because you're disrupting normal childhood development. And if you're doing that, you're setting the train off on a very bad path. And so it's even more important to get the right diagnosis. And with that, there have been incidence and prevalence estimates, and it's somewhere between 1% and 2% probably for full bipolar disorder in children and adolescents in the U.S. Now, in your slide set, you have some slides that will not be presented here in the interest of time, but were included just to give you a little bit more complete picture about the talk today. So we jump over a couple of slides, and we're talking now about early signs of bipolar disorder. So how do we first identify bipolar disorder? What are the earliest signs? Sometimes even before the first full manic episode. We know that the hallmark of bipolar disorder is mania, right? So that's what we're looking for. But when we're talking about early signs, sometimes other more subtle clues can point us down the right path. And clearly, when you have children who have mood dysregulation, such as high irritability or high reactions to social stressors, brief periods of euphoria, temper outbursts, that's a sign of mood dysregulation. Again, it may be something that appears very early, and it may be very normal. And back in the 1990s and 2000s, you guys are a very young crowd, so I'm not sure if you were around then, but I think that I was, unfortunately. And during that time, we had a lot of kids with big temper tantrums and big irritable outbursts, and then there was some thinking, well, maybe they have bipolar disorder. And so they would come into the clinic, and I was still at Stanford then, and we would go through all the symptoms, and many of them would not have the full manic picture, but they would have these really big irritable outbursts. And it turns out many of them actually had depression. Many of them probably had autism spectrum disorders. A large proportion had anxiety. But then there was also a large proportion who had bipolar-ish symptoms, you could say. And then there was another small percentage that had full bipolar I disorder. So temper tantrums and irritability by themselves are probably usually not indicative of bipolar disorder. But it's still something to rule out. It's very normal as a child to have irritability. It's very normal to have mood lability. But you have to know at what age does it occur. And we'll talk to this, about this in a little bit in a future slide, that developmentally you have to be aware of when is it normal to have mood lability. As a 2-year-old, it's pretty normal, right? As a 6-year-old, it's pretty normal. As a 10-year-old, it depends. You're not really looking for temper tantrums as a 10-year-old necessarily. And by the time you're 16 and 17, 18, well, I should say, once you go into adolescence, all bets are off, and it becomes another psychotic episode for another 3 years. I have 2 adolescents myself. But you have to know, again, in the context of adolescence, what is normal adolescence, which is very hard to understand, and what is severe mood lability. But what can help you identify it is looking for more specific symptoms of mania, which we'll get to in a second. Other signs include ADHD. So again, a very commonly presenting disorder in youth. And not all kids with ADHD have bipolar, but it's a very common starting point. And as Dr. Rob will tell you later, it's incredibly comorbid the earlier your onset of bipolar disorder. So often it is the first sign that you're going to develop bipolar disorder. But it doesn't mean that you will for sure. But it's a clue, and it's a clue that you should look further for mania. Now, depression is probably a little bit more specific because the earlier that you have a depressive episode, the more likely you are to develop mania. In fact, there's only been a few studies, but they point out that up to 30% of youth who have their depressive onset prior to age 12 will have a manic episode. And about 20% of adolescents who are depressed will have a manic episode. And again, in that slide that I showed you, that pie chart where they asked adults, what age did you have your first full mood episode? Mostly it was depression, and mostly it occurred before 18. So depression is a very common presenting factor. And sometimes you have a child with depression, and they don't have mania, but you have to check to make sure it's not a bipolar depressive episode, which we'll get to in a second. But very often the depression will then lead to a manic episode if we are not treated correctly. And finally, anxiety. And anxiety is very difficult to understand because it is so common and such a normal part of development and part of our human experience, and very common, as will be talked about in the comorbidity talk. But it's also a sign that there's a lot of stress going on. And so a child with high anxiety is not a very calm child. And so there's probably a lot of stress that then leads to mood dysregulation that then can set you up for bipolar disorder as well. And so we're only beginning to understand how anxiety presents first in these children, but it's also how they comorbid once the manic episode has occurred. And remember, again, by themselves, it doesn't mean that the child has bipolar disorder or will definitely have a manic episode, but it increases your suspicion. And so anytime you have a child presenting with any one of these, which is probably most of the time, right? How many people here are child people? How many people see adolescents? How many people have children? How many people feel like a child right now? Like cranky, little, that's how I feel. All right, okay. So good, well good, you're at the right place because, you know, I think it's very important to realize that there are many, many reasons to have these symptoms. But once you start putting these symptoms together, and then once you start seeing the manic symptoms, that's when you start seeing a picture of bipolar disorder. Now, the more we realize that this is a spectrum disorder, the more we will be able to better identify it. In other words, we know that kids live on a spectrum. It's not like they either have bipolar disorder or they don't. Okay? The days of the great premorbid functioning leading to a sudden manic episode in their adolescence or during collegehood, that still occurs. But it's not the most common presentation. We're realizing now that very often there's a premorbid, there's an early bunch of years that the kids are slowly developing these disorders before they have their first full manic episode. And these kids can present as pretty sick during this time, even though they don't have full bipolar. So that's why it's important to recognize this whole spectrum. And on one side, you could have what's called severe mood dysregulation, or now what's more commonly called disruptive mood disorder, which we'll talk about in a second as well, too, which is basically just what I talked about, that mood lability and not being able to control yourself and having big temper tantrums and irritability, possibly euphoric periods as well, too, but not having the full manic picture. And then we have other things that we talked about, things like ADHD and depression. And if it's presenting in the context of a strong family history of bipolar disorder, say a parent with bipolar disorder or uncles, aunts, that should raise your index of suspicion. And then we have something called bipolar not otherwise specified, which no longer exists in the DSM. But back in DSM-4, we used this to classify a subset of children who didn't meet full mania criteria, but met a sub-threshold version of that that we thought was very predictive of progressing to that, and I'll show you that in a second, to the kids who finally have full bipolar 1 or 2 disorder, okay? And so just because you don't have full bipolar 1 or 2 disorder doesn't mean that you're not ill. It doesn't mean you're not on the spectrum. It means that you have to identify what the risk is to get to there, or if they're already there, you have to identify it correctly and treat it correctly. So in a few different studies, we found that indeed these are prodromal presentations. In other words, these are kids who are at high risk for progressing to develop these disorders, especially those kids with bipolar disorder not otherwise specified. In one study, and I'll show you here, whoops, I thought I had the study here, maybe it's coming up. Oh, it's coming up when we talk about NOS, but these kids have high rates of developing full bipolar 1 or 2 disorder over 4 years. Over 50% of kids who have a family history of bipolar disorder and BDNOS go on to develop this. And I'll tell you in a second how we characterize children with BDNOS. It doesn't mean the old DSM-4 criteria, which are basically no criteria. There's actually, we use very specific criteria to identify these kids and put them into this category, and I'll tell you that in a second. So that's the spectrum, but I'm realizing that I'm here to talk to you more about bipolar 1 disorder. And it's important because even if they don't have full mania, you need to know where they are. But if they do, then they qualify, of course, for bipolar 1 disorder. That's the hallmark. And that's the manic episode. If we draw a mood chart like this and mania is up and depression is down, you've seen this a million times. Depression does not give a specificity towards diagnosing this, mania does. And so I'm going to concentrate on how do you diagnose mania in a child or an adolescent, okay? Now, how many folks have seen a child, an adolescent with bipolar disorder? Okay, good, very common. How many people have seen a child under the age of 12 with bipolar disorder? Dr. DeBello, Dr. Rob, I'm surprised. No, I'm not surprised to see that. Okay, I'm sorry. Out here, okay, there we go. So how about under the age of 6? Now we're getting more controversial. Okay, all right. How about in utero? How many people have seen in utero? No? Okay, as a test, just to make sure we're not over-diagnosing it. Eventually we'll have that technology, but currently, no, we don't have that. So it becomes harder and harder and rarer, as you can see by the show of hands, that it is a more and more difficult disorder to diagnose and potentially a more rare disorder the younger you get. And I think both those things are true. But I do think it becomes more and more difficult based on the normal developmental processes we talked about. So in order to get this information, I broke this down into some very basic steps. And we know that in 25 minutes we're not going to all become experts, but I expect fully about 2/3 of you to become experts within 25 minutes. So we're going to do our best as we can. First of all is the interview. Okay? It's very important. The interview is super important because, again, there are no biological tests, right? There's no brain imaging, there's no blood tests, there's no genetics yet that are going to help you diagnose it. No matter what people say, there really aren't. So at this point, it's still very much a clinical interview that you have to get information from multiple sources. You have to talk to as many caregivers as you can. And you have to realize that parents may be more reliable for reporting on symptoms of mania than teachers or youth. And that's been proven in a couple studies. And so it's okay to get that information from the parents. It's okay to get it. It doesn't mean that they're biased or that they're anxious or that they're worried. All those things are true. And as a parent, you know that, but it's still important. They are still the best reporters as far as for manic symptoms, especially the younger the children get. Now, for more internalizing symptoms like depression or how much do you sleep, especially in adolescence, you have to interview the child directly. And a lot of that information the parent might not know or might not be as good as reporting. But the externalizing symptoms and the symptoms of mania are more reliably obtained. But you've got to get them from both sources. Okay? Now, teachers, they typically don't observe the hallmark features of mania because they don't see them at bedtime, they don't see them at home, and a lot of times they attribute their difficulties to ADHD or being oppositional, and so you have to be careful, but it's good to get also the educational feedback as well. Okay? And in fact, what I usually say is that if you're getting multiple reports from different places about similar behaviors, home, school, friends, the more you have, the more severe disorder is. If it's only happening at home, and people are saying, well, it's not real because it's only happening at home, it must be a parenting issue, it's not happening at school, it doesn't necessarily mean that. It could be a factor, and it often is, but it usually starts that way because that's where the child feels most comfortable. And only when it becomes a more severe disorder that it's difficult to regulate the mood in other circumstances, other environments, in front of strangers, in front of other relatives, then it's a more severe disorder. Okay? So it's important to catch it before they get there. Okay. Family history, I'm going to say, is very important. It's super important, but it's not decisive. In other words, if you have a positive family history, it's going to lead you down a path, but it doesn't mean for sure the child has bipolar disorder. But you should really carefully ascertain that also in parents who are often underdiagnosed and undiagnosed. And so you should check to make sure that the mother or the father with a depressive background doesn't have bipolar 2 disorder or bipolar 1 disorder. So you should check on that. The chances of a youth having bipolar disorder with a parent with bipolar disorder are fairly high, about 15 to 20%. Now I'm going to spend the next few minutes just talking about mania. But again, these are in your handouts, and so in the interest of time, I'm just going to say that there are a few things that you should look for specifically. Now, of course, you should look for the primary diagnostic criteria for mania, but you should also look for it on an age-appropriate level and get collateral information when you're doing that. There's a Grapes mnemonic that can help you remember this as far as looking for grandiosity, racing thoughts, activity that's goal-directed, pressured speech, elation, and sleep disturbance, okay? And so let's go on and talk about that. So that's the manic episode. We'll get back to that in a second. But what about an episode? This is often the sticking point in diagnosing bipolar disorder in kids because it's difficult to pinpoint a whole week where this mood is happening because kids, again, normally change moods so frequently that sometimes it can be hard to tell. Now, clearly we need to look at a week-long episode. That's a criteria for mania. Now, of course, it was artificially created, for adults with bipolar disorder, so it may not be the best criteria we have, but it's still what we go by, and so we want to speak a common language. And so what we tend to do is to look for an episode that lasts a week, but it doesn't mean that their mood has to last a whole week. It doesn't mean they have to be irritable for a whole week straight or euphoric for a whole week straight. It just means that that has to be the predominant change during that time. So very often, we'll ask the parents, like, when did this start happening? Or when was the worst period of time that you've noticed Johnny's mood to be in? And if it was like October, was it 3 weeks in October, 4 weeks? And during that period, what was the difference in mood? And during that period, did they have these other symptoms during that period as well? It doesn't have to be every minute of the day. In fact, a new DSM-5 says it has to be, a predominant. It doesn't have to be every minute of the day, but a predominant mood. And in fact, even in adults who have mania, very rarely are they, manic 24 hours a day. There are periods where their mood comes down. But in kids, that's how we tend to do it, okay? So 4 days is hypomania, and for BDNOS, it's 4 hours with one less symptom A criteria. So that's something that we'll get to in a second if we have time. So the idea is to look for these meta episodes and to go ahead and make the diagnosis during that time. Now, I'm not going to read this slide, but this is talking about the symptoms of mania, and highlighted are those cardinal symptoms, those symptoms that don't usually appear in other disorders. Things like grandiosity. Okay, having grandiose delusions, not very typical, but for bipolar disorder, it's sort of a hallmark. Same with a decreased need for sleep, not just trouble falling asleep, but actually getting less sleep than normal. And you have to know then what's normal for that age range, right, of the child. But having less need for it and then being energized and not needing to be tired or sleepy and just going on about their day. Racing thoughts, not just thoughts that are jumping and being distractible like a child with ADHD, but actually thoughts that are racing and maybe uncomfortable in their head. Increased goal-directed activities such as having to draw a lot in books or cook pancakes in the middle of the night, or things that are more age-appropriate than starting new businesses, although some kids do that too, or having multiple sexual partners, although some adolescents do that too. You have to make it more age-appropriate, okay? Just know that DSM, as I said, they changed some of the criteria, so it has to be a noticeable change from baseline. It has to be just predominantly most of the day, nearly every day during the time. They also added DMDD, and I promised I would talk to you about disruptive mood disorders, okay? And I will in 1 second. I'm not going to go into depth about this slide, but just as I mentioned, each of these manic symptoms need to be age-appropriate. Children are not going to have credit cards, so they're not going to be maxing out their credit cards during manic episodes. But instead, they'll be doing things like risky behavior or sexuality. They may be more interested in self-stimulation or talking about it, or grandiosity. You have to know what age is it normal to think you're Superman. Sometimes it's okay, and sometimes it's not. I want to mention that ADHD is a very important comorbidity because, again, it presents very frequently with bipolar disorder. But then how do we do this? Because kids with ADHD often have a lot of energy and are speak fast and are very distractible. How do we differentiate that from mania? And again, that's probably a 2-hour talk right there. But one thing that you can just say is that, you know what, you shouldn't count the symptoms twice. If they have ADHD as their baseline and their hyperactivity and their distractibility don't change during the manic episode, then you really shouldn't count those as symptoms. But what if their distractibility and their speech go up during that period, or the energy goes up during that period? Then that's when you start counting it. Okay, so it's important not to count it twice. And finally, NOS. Briefly, I'll just talk about the fact that this is something that we realize many kids present with. Unfortunately, we don't have studies about how to treat kids with NOS, but we know that high percentages of them will go on to develop full bipolar, and already most of them are impaired just as, if not more than, kids with bipolar I disorder. And again, the idea is that they can have one less symptom of those manic symptoms, and it has to happen during at least 4 hours, but it has to happen repeated times and cause impairment. And there are many kids that you can make this diagnosis, and it's helped me throughout the years make this diagnosis, because then we realize, you know what, this is a subset of sick kids who probably should be treated as if they have bipolar disorder. And this is just a slide showing that conversion rates over time, especially with the family history, in kids with BDNOS are very high. So DMDD, just know that it is a disorder that was put forth and studied a little bit before it was put forth to try to catch these kids who have chronic irritability but don't have mania. So it's basically a child who has to have chronic, ongoing irritability without this manic episode that we talked about with euphoria or the irritability along with those manic symptoms that we just discussed. And they have to have a negative mood between their outbursts and have to have onset, before age 10. So this is a little bit of a controversial, in my mind, diagnosis because it hasn't been well studied and we don't know really what it means. And in studies that have come out since this disorder was proposed, it doesn't seem to be a very stable disorder. In other words, it changes over time. And kids who have DMDD may, 6 months later, not meet criteria for it, or may come back, and it may be cyclical. And it may actually predict outcome of depression more than bipolar, but since then we've realized that it probably is a nonspecific starting point and that you can have many different kinds of outcomes with DMDD. My concern has always been that clinicians will miss underlying reasons for this irritability, such as more depressive disorders or pervasive developmental disorders or anxiety. And so you should really look for those things underlying causing the irritability and go that direction. Because what happens when you treat somebody with DMDD? What's indicated to treat children with DMDD? Exactly, nothing. So we don't really know what we're supposed to do. So how does that help us? It doesn't, but it helps us at least say, wait, this is not full mania. What is it? And can we go down a different pathway? So that's why I think the utility of something like DMDD. I won't talk about comorbidities because Dr. Rob is, and I think I have about 3 minutes left to talk about cases. And so I'm going to go ahead and specifically hone in on these cases. Okay, so case 1 is a 16-year-old girl with high irritability and anxiety who's got a history of depression on both sides of the family. And she herself has significantly depressed mood, suicidal ideation. She's irritable, she's tired, she's sleeping a lot, she's staying home, she's staying away from friends, she's not wanting to be out in the world. What does this make you think about? Well, hopefully it makes you think about depression, because that's all I've been saying, is that she's got a history of depression, she's got all these depressive symptoms, and that irritability in a child is a sign of an unhappy child. Okay? It's not a sign typically necessarily of a manic child, but it could be, and you have to rule that out. But in this case, you want to go ahead and say, hey, what's going on with depression? Is there any substance abuse? Is there any trauma? Let's go ahead and diagnose depression first and get all the diagnostic criteria out of the way, and then let's go ahead and see if there's manic episodes, and see if there are bursts of euphoria or irritability, see if there's increased goal-directed activity, racing thoughts, things like that, and see if you can get an episode where these things are happening together. But starting off from depression, even with this child is probably at a high risk, of developing mania eventually. And if they had a parent with bipolar disorder and a full depressive episode, we don't know exactly what risk they are, but we are guessing, and I've always guessed, that it's pretty high, and maybe 30 to 40%. So this is a very important case to consider. Now, what about this boy? Case number 2 is a 10-year-old boy with high irritability and anxiety. Sounds familiar, right? But he had sudden onset of anxiety a week ago and gradually became more behaviorally dysregulated, had anger outbursts, and like high energy and manic-like behavior. But he also had repetitive speech patterns. He had a lot of separation anxiety and was sniffing his hands repeatedly. Was very afraid to go outside or leave his parent. Had difficulty sleeping at night. And this kind of happened fairly suddenly about a week ago. And it also happened after he had a strep infection about 3 weeks ago. All right, I heard someone say pandas. And so, yeah, this could be something like a neuropsychiatric disorder. I've seen many kids, something like pandas, which is pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. Or it could be PANS where you don't have evidence of a strep infection, but yet you still have this sudden onset. And again, this might be the next controversial disorder but it's really been 20 years since it's been described, so it's less controversial now. But in some areas it is. But clearly, once you see a child with this and treat them with antibiotics or treat them with anti-inflammatories and see them get better, you know that this is not your typical OCD or typical mania. I've seen plenty of kids present with mania or depression who probably have PANS or PANDAS or did have PANS or PANDAS and are treated completely differently. So this is not a PANS or PANDAS talk, but it is something in the differential when you see someone with high irritability and anxiety. And finally, what about a 14-year-old girl, again with high irritability and anxiety, who has periodic bursts of creative energy, high activity, is really into writing poetry and writing screenplays, and periodically she'll stay up at night and keep writing them. During that time, she gets rapid speech and elevated mood. She calls them her hyper periods. My friends just think I'm being really silly during that time. She could be. It's pretty normal, right? But again, during that time, how silly are you compared to your friends? Do they say you're kind of the outlier? Do you ever get in trouble during these times? Do you miss appointments? Do you forget things? So that's what you have to look at to differentiate what's a normal adolescent silly period versus a manic period. And again, a family history of bipolar disorder would help you make this diagnosis. So this is actually, a real case. I've seen many real cases like this. And what you have to do then is hone down on the mood and say, hey, during these high irritability periods, do you have euphoria? During these euphoric periods, how long do they last? And during those periods, do you have those other symptoms of mania that are different from baseline? And if you do, and if it's very short acting, it might be NOS. But if it is 4 days or 7 days, it might be bipolar I disorder. So it's very important to make that distinction, as Dr. DeBella will tell you why when we talk about treatment. So in conclusion, bipolar disorder is not uncommon in youth. Patients often present with depression, ADHD, or irritability, and they may have underlying mania, or they may be at risk for developing it, or they may have other conditions, and you have to be very specific when trying to parse that out in a child, especially when they're young. And so careful interview with as many informants as possible is very important. You can use structured interviews if you like, but almost no one does. But we love using structured interviews because we do it for research, and that helps you kind of hone in on the symptoms of mania. And of course, family history is very suggestive, but it's not diagnostic. So thank you very much for your attention, and welcome again. The next speaker is Dr. Adelaide Robb, who will talk to you about comorbidity.
Thank you, Dr. Chang, and luckily the podium is low enough so that you can see me over the top of it. So glad everybody's wide awake. Poor Dr. Chang, he's on California time, so giving a talk at 4 o'clock in the morning is hard. Maybe it's 5, but it's really early. So he queued me up. We're going to talk about comorbidity. I'm just going to put up my disclosures. I work with a lot of different companies, and I want to thank Synovian for giving us an educational grant to talk to you about this. So we're going to talk some about psychiatric comorbidities, and we heard a bit about that from Dr. Chang, things like anxiety and OCD, ADHD, that magical disruptive mood disorder, and substance use, which complicates bipolar for patients both in the pediatric spectrum and in the adult age group. And then some medical comorbidities, because this gets us into trouble with our pediatric and internal medicine colleagues. So when we look at comorbidity in adults, we find that about 75% of them have problems with anxiety, and over half of people with bipolar have things like ADHD or other disruptive mood disorders, substance use disorder, and other issues. And metabolic syndrome, and for some reason, migraine headaches are two of the more common medical comorbidities. But what we really want to do is treat our pediatric patients so they get mood control and so they don't end up developing some of these psychiatric and medical comorbidities that our adult patients have. So the next couple of slides, which are all in your handouts, are 3 large phenomenology and/or treatment studies of pediatric bipolar disorder. And part of what we do is we do a big case ads interview where we screen in and out every other axis 1 disorder. So the COLT study, which is the lithium trial funded by NICHD, looked at 81 kids. Dr. Dilbello was one of the sites on this one. And ADHD was the most common disorder, with over 60% having ADHD, but other disruptive mood disorders, or disruptive behavioral disorder, sorry. So that's oppositional defiant conduct disorder. Bedwetting was common, and that was before we gave them the lithium, not after. And anxiety disorders in up to a quarter of the patients. Other things we found, marijuana use disorder, because it was up to age 17, so by then people were using marijuana, tic disorders, and hair pulling. When we look at the COBE study, which you heard about already from Dr. Chang, and the family-focused treatment for bipolar disorder, they found again that ADHD was probably their most common, but oppositional defiant, anxiety, substance use, and that was the family-focused treatment one. And in COBE, they found psychosis, and it was a psychosis NOS. It wasn't schizophrenia as a comorbidity. But again, ADHD most common, but things like anxiety in up to 39% of patients, and even autism, pervasive developmental disorder, in about 2% of kids with bipolar. What about that DMDD diagnosis? I think you saw from the audience response that Dr. Chang did earlier that a lot of us, and I would say even in the field of child psychiatry, are a little bit confused by what is this diagnosis, what does it mean, how is it different than bipolar, and how do we clarify that? And when the people who had done the COBE study went back and looked at all their BPNOS kids and said how many of them would fit the DMDD diagnostic criteria instead, they wanted to sort of help clarify what's the difference, BPNOS, DMDD. It really is that the DMDD people, as Dr. Chang already told you, are just chronically irritable and grumpy, but they don't have that episodicity or the hypomania episodes that we see in BPNOS. And that's the big differentiation. There's a couple of papers about that. Ken Tobin did this one looking at it, but you really need to pull for the manic symptoms if you want to say, all right, you don't have DMDD, you're just chronically irritable. So I'm going to give you a case example. And I know Dr. Chang said kids don't have credit cards, but you'd be amazed how many people can get on Amazon with their parents' credit card and order all kinds of things. And that's usually what we see. So this is a 12-year-old. He's in the 7th grade. He's been staying up all night. He ordered himself a laptop and a gaming system from Amazon. He started texting his older sister's friends in high school and wanted to arrange hookups. He's talking nonstop. And he's on a mission to computerize the Amazon rainforest. If he was 25, you'd have no problems making the diagnosis, right? But he's 12, and yet kids can show up with some of the same symptoms. But here's the other part of it. He's still got anxiety symptoms. He's following his dad everywhere. He won't go to Boy Scout sleepaway camp because he doesn't want to be away from home. He had a panic attack when he was standing up in front of a much smaller room than I'm standing in now. And he worries about all kinds of things. How's he going to do on the baseball team? Are his friends still his friends? And so he's got all these other comorbid symptoms. So we know that anxiety in adults is one of the most common disorders. But how do we treat anxiety when it shows up in bipolar? If you just have anxiety disorder, it's easy, right? If you need an SSRI, we can give you one. If you need CBT, we can do that. But when you have bipolar, we're not going to give you an SSRI or an SNRI. They're both FDA approved for different anxiety disorders. So we have to eliminate pharmacologic management and go right to cognitive behavioral therapy. And CBT is great, but I don't know where you are in the country. It's hard to find people who are good at pediatric CBT who will take insurance. That's the hard part. And we know from the COBE study, where they tracked the different subsets of patients, that those with anxiety disorder had less good outcomes over time, because they followed the kids in COBE out over a year and 3 years, and if they keep getting funding, they will continue to follow them. They had higher lifetime rates of antidepressant use, even though we don't like to use them. They didn't vary compared to their non-anxious cohort partners in the use of psychotherapy. So we've just said CBT would help, but they didn't get extra CBT. The other thing is they had more mood recurrences, they had less time in a euthymic mood when they had comorbid anxiety, they had more mixed episodes, and they had more depressive episodes. So having a comorbid anxiety disorder predicts in some ways outcome for your bipolar pediatric patients. The other thing that's very common, especially in our adolescent bipolar patients, is substance use. And using motivational interviewing and getting them into 12-step programs are helpful. But some of the older studies tell us, and this is more on adults with bipolar who have comorbid substance use, that the mood disorder preceded the substance abuse or use, we don't say abuse anymore, we say use disorder, by several years. So we have in child psychiatry that magic window where if we make an accurate diagnosis of bipolar, we intervene with good treatment, medication and therapy, perhaps we can prevent the development of substance use disorder. And if we were listening to Tim Weiland's give you a presentation on ADHD and substance use, we know now from very good large studies in ADHD that good treatment of ADHD can help lower the rates and the development of substance use disorder. So what we're hoping in bipolar is we can do the same thing. If we get an accurate diagnosis, and now that we have good treatments that are FDA approved, initiate those, can we lower the comorbidity rate in our adult population or even our adolescent population of substance use? That's our goal with early treatment and intervention. But ADHD is our big comorbid diagnosis. And what do? People come to us all the time. I've got a kid with ADHD and bipolar. What do I treat first? We always say stabilize the mood first. Get that mood under good control. Get somebody euthymic. If they still are having ADHD symptoms that are interfering, you can then judiciously add in a stimulant or an alpha agonist. We tend not to use atomoxetine because there are some thoughts that it's an antidepressant-like drug, right? It's a norepinephrine reuptake inhibitor, and that may actually precipitate more episodes of cycling. And in the treatment of early age mania study, which was another one of the large federally funded trials, where it was kids with bipolar 1, they had high rates of ADHD comorbidity, and they were randomized to risperidone, lithium, and valproic acid. If you had comorbid ADHD, you were more likely to be a good responder to risperidone, which in that trial was overall the best drug, compared to lithium, which was in the middle, and valproate, which was the least effective. But if you didn't have ADHD, if you just had bipolar, lithium was equally effective to risperidone as a first-line treatment for bipolar. And I think that's really important when you're thinking about treating a child with bipolar disorder. Russ Schafer did a study many years ago that was published in 2005 of kids with bipolar disorder and ADHD, and he stabilized everybody on valproic acid. And then what they did is they randomized them to either placebo or Adderall, mixed amphetamine salt, sorry I used the brand name, and looked at the control of ADHD symptoms and also did it make cycling worse. What they found is, again, if your mood was under good control, mixed amphetamine salts were superior to placebo in controlling ADHD symptoms, but your mood didn't get worse. And in many of the antipsychotic registration trials for bipolar 1 in kids, people are coming in with an ADHD comorbidity, and in some of the trials, they were allowed to stay on a stable dose of stimulant. And if they stayed on a stable dose of stimulant and they added in either placebo or whatever antipsychotic was in the trial, they still had good control of mania, and their ADHD symptoms didn't get worse. So that's been done many times in registration trials. They're all laughing over there, but that's okay. So here's my next patient, and we're going to switch gears now and start to think about medical comorbidity. 16-year-old girl in high school. She's been diagnosed with bipolar 1. She is on oxcarbazepine for her bipolar disorder. I know it's not FDA approved, but that's what worked for her. And on mixed amphetamine salts for her ADHD. She's at sleepaway camp because she does not have separation anxiety. And she's at camp and she doesn't feel very good. She stops feeling hungry, she starts losing weight, and she comes back from camp and she sort of thinks, oh, I was at camp. You know, camp food's horrible. Anybody who's been to summer camp knows that. And she goes to her primary care doctor thinking she got the stomach flu or something like that. And she's lost 25 pounds in a couple of months. Her BMI is still elevated. It's at 27. But her serum glucose is 525, and she's got 3+ ketones on her UA. She's got a family history of diabetes, and she ended up 2 months later then developing celiac disease. And that's not uncommon, apparently. I learned this from my patient, that about 10% of people who get type 1 diabetes also end up getting another autoimmune disorder, which is celiac. And so now, in addition to having bipolar and ADHD, she's on insulin and a gluten-free diet. So I think I use this as a warning because even in patients who are not horribly overweight, although she was overweight, you can get diabetes when you've been medically stable for a long time. So I always want people to have in the back of their mind, if somebody's not feeling well and they have a rapid weight loss, please send them to their primary care doctor if you're not following their labs and get them checked out. And you're the best advocate for your patients when you're worried something's medically wrong, because I know we've all had this experience that we'll have a patient that we're treating for a psychiatric disorder. They're not feeling right. Something's medically wrong. You send them to the doctor and they get dismissed because they have an Axis I disorder. So you can be a good advocate and reach out to that primary care doctor and say, I'm worried about my patient. So there have been a couple of large cohort studies, one of them in South Carolina, where they looked at 1,800 kids with bipolar disorder and then another 4,500 age-matched controls who did not have an Axis I disorder. There were 10 different conditions that were actually more prevalent in the bipolar cohort, including things like obesity and diabetes and migraines, but also things like ADHD and substance use. And those teens with bipolar who had onset in their adolescence often had pre-existing weight problems, high blood pressure, intellectual disability, and endocrine disorders, as well as pre-existing substance use at the time of diagnosis. This is a very busy slide, and it's very scary, but I want you to sort of look at Table 2 more than Table 1. You have it in your handout, and you can see it later. But what you really sort of want to look at is when they compare the bipolar to the non-bipolar age-matched controls, what's got a higher rate of risk? And they are things like endocrine disorders with a higher risk of 2. I'm going to turn with my back to you. You can still hear me, and I'll just point to this. So endocrine disorder is more common. Obesity and weight gain are more common. Epilepsy is more common. And substance use disorder is much more common in the bipolar cohort. So always look for comorbidity. Even if they're coming into you, I always ask about other medical problems and family history. So my kid who ended up developing diabetes had a family history of diabetes. I always ask about that. So they also took the same cohort of kids, they've got a huge South Carolina medical system apparently, and looked at were certain medications more commonly associated with certain medical conditions. And what they found is kids who were on second-generation antipsychotics and stimulants were more likely to have elevations in blood pressure. And we know, right, stimulants elevate your blood pressure, but apparently also with the SGAs, and have cardiovascular disorders in general. For the people who were on the SNRI antidepressants and the heterocyclic ones, more likely to be obese and overweight. And for those on the SSRIs, for whatever reason, more commonly associated with asthma. That does not mean they cause asthma, but that seemed to be the one finding they found for the kids on SSRIs. So what do we do to help our patients when they start to have metabolic issues or we're concerned about it? Well, we always want to remind them, and we talk to our patients longer than the 6-minute visit with the primary care doctor, so we can do a little counseling. Low-calorie, low-fat diet. Some people even go on those high-protein diets if that's easier than having any kind of carbohydrate for them. You want to have them improve their exercise level, and that's where we advocate for PE and after-school sports. Family meals, just the way they're great for treating eating disorders, they're also helpful for reducing rapid eating and high-calorie options. So sitting down and having a real meal rather than going to the takeout at the local fast food restaurant. Bringing lunch from home instead of having the school lunch usually also gives you better options. And using water and fat-free milk as the only beverages. Many parents will give you a juice box because they think it's 100% natural, but calories that come from liquid don't contribute to satiety, and so people don't feel more full. So if you're drinking a latte or you're drinking 5 chocolate milks, that's a lot of calories and your tummy's not filling up. And so that's going to contribute again to weight gain. Just switching to water makes a huge difference for patients and they don't feel deprived. And so you want to do both. What the calorie reduction does is it leads to weight loss. And what the exercise and building muscle mass does is it actually reduces insulin levels and improves the use of insulin in the system and glucose control. So do both. That's what the endocrinologists always tell us. And I'm going to Can I touch briefly on the metformin trial, or is the hook coming, Dr. Del Bello? Okay. This is a trial for kids who had gained a lot of weight on an SGA, comparing metformin titrated all the way up to 850 BID versus placebo. And what they found, and you can see it right here graphically, is both the weight gain, and metformin's in blue, and blue is better. They gained very little weight on metformin prospectively, and their BMIs actually dropped a bit, while the kids on placebo continued to gain weight on antipsychotics. So it is one way to manage that bad weight gain that you see in some patients. And I'm just going to remind people that comorbidity, whether it's medical or psychiatric, is the name of the game in pediatric bipolar disorder, and we're going to let Dr. Del Bello hit it home.
Okay, so we're almost done. I'm going to be talking about pediatric bipolar depression, and we're going to talk about management strategies. I want to disclose affiliations with a consultant or advisor or research grant support. And we will be talking about unapproved uses of medications, since we will be talking about treatment of bipolar depression. Okay, so treatment of bipolar depression in kids has been largely ignored, as we'll talk about. Most of the studies that have been done to treat children with bipolar disorder have focused on mania and treatment of manic episodes. In adults, though, as you know, there are 3 medications that have been approved for use for bipolar depression: quetiapine as monotherapy, OFC, and lurasidone as monotherapy or adjunctive therapy. So there have been 3 different medications approved. It is OFC. Olanzapine fluoxetine combination is the only medication that is FDA approved for acute episodes of depression in children and adolescents with bipolar disorder. You can see that we have 6 different options of medications that have been approved for acute manic episodes. And for longer term or maintenance, we have lithium and aripiprazole. But right now, only OFC is for acute bipolar depression in children. And we'll talk more about those data that led to the approval in a minute. So what is depression associated with bipolar I disorder? You heard a little bit about it before, but it just means that you've had a prior manic episode, and currently you are having a major depressive episode. It is not a mixed episode, so if there is both manic symptoms and depressive symptoms happening at the same time by DSM-5, you have a manic episode with mixed features. So mania sort of trumps depression by DSM-5. So what we do know, though, about depressive episodes in children and adolescents with bipolar disorder is that those tend to be the more severe episodes. They last the longest, and they have the lowest rates of recovery. Despite that, we still have only 1 FDA-approved treatment. There are other options potentially for treatment. We'll talk a little bit about non-pharmacologic treatments that have been shown to be effective. Antidepressants are commonly used, but we'll talk about some of the shortcomings of antidepressants. And then we have data with all of the other options that are listed. We'll go over those. So non-pharmacologic interventions. And these have actually been shown, especially FFT, family-focused therapy, which is David Miklowitz's therapy that is manualized, relatively brief, and has been shown to be very effective for depressive symptoms in children and adolescents with bipolar disorder. Other types of therapies may be effective: stress management, regulating sleep cycles, mood charting to figure out triggers for depressive episodes, regular diet, decreasing substance use, and support groups have all been shown to reduce some symptoms of depression, but not generally as monotherapy, all as adjunctive to pharmacologic intervention. So where do we stand with SSRIs? There have been some small retrospective case reports and case series that suggest that SSRIs may be the most effective treatment for bipolar depression in children and adolescents. However, they also increase the risk of relapse to mania, in children particularly. So they're good at getting patients, children, out of the depressive episode, but when maintained on an antidepressant as adjunctive treatment, they can flip the patient into a manic episode. We have also done some research that has shown, in particular in younger children who are at risk for bipolar disorder, so they have a parent with bipolar disorder and they themselves have depression or anxiety, which may be prodromal to bipolar disorder, that the younger the child, the more likely they are to have adverse effects to antidepressants. And these are adverse effects like psychosis, hospitalization for suicidality, and particularly if you have a parent with bipolar disorder and you're 8 years old, you have almost 100% chance of having a bad reaction to an antidepressant, versus if you're on the older age range, young adult, then your chance of having a bad reaction to an antidepressant, if you have a parent with bipolar disorder, decreases. So SSRIs need to be used with very extreme caution in this population. Other studies have shown that bipolar kids who have bipolar 1 or bipolar 2 or BPNOS, when an antidepressant is prescribed, they are at higher risk for having negative reactions, and particularly about a third of bipolar 1, bipolar 2, or BPNOS children have, when exposed to an antidepressant, have a new onset of suicidal ideation. So they have to be used with caution if you think that's the best option, and started very slowly, titrated. There are some patients, though, for whom an SSRI is necessary, but very low dose, and again, very much used with caution. What else do we have as options for treating bipolar depression? So there was a study that Dr. Chang performed with lamotrigine in children with bipolar spectrum disorder who presented with depressive symptoms. And you can see basically the measure that we use to rate improvement in symptoms is the Children's Depression Rating Scale, the CDRS. And basically, to get into most studies, you'll see you have to have 40, 45. And the bipolar depression studies, generally the children have around 60. So they're more severe when they're depressed. They have a lot of symptoms. You can see here that there was an improvement, and this was as adjunctive treatment in some cases, but there was significant improvement over time. But when they ended the 8-week study, it only had improved to in the 30s. And so they were pretty significantly depressed still. But there's some indication that lamotrigine may be useful. Lamotrigine generally has to be titrated very slowly, as you know, because of the risks of Stevens-Johnson's. And so it's not something, if you have a patient who's severely acutely depressed, that you're going to want to take the time to use and titrate and use correctly. We did a study with lithium. Again, this was an open-label study of monotherapy with lithium for bipolar depression. Again, the children were pretty significantly depressed when they went into the study, but after, and this study was 6 weeks, after 6 weeks of the study, the CDRS score was around 40 on average, which is sick enough to get into most bipolar depression studies. And this is open label, so not placebo-controlled. So there are side effects, as you know, associated with both lamotrigine and lithium. Lithium, we did have high rates of GI side effects, nausea, vomiting, polyuria, polydipsia. And lamotrigine was fairly well tolerated. There were 2 patients in that study that had a rash, but generally they're both fairly weight tolerated, not huge weight gains. Both had some weight gain associated with it. So what do we know about double-blind placebo-controlled studies? There have been 2 studies with quetiapine. One study was a 2-site study that was at our site and as well as Dr. Chang's site, and we had about 30 patients in the study, double-blind, placebo-controlled study, and as you can tell, there was no difference between improvement in CDRS scores in quetiapine group versus the placebo group. They both resulted in significant reduction in depressive symptoms, but there was no difference between the groups. And so this was an 8-week study. What was very reassuring is when the quetiapine extended release study then was performed, and this was a much larger study of bipolar 1 or bipolar 2 depressed children. The CDRS to get into the study was 45. It was a little bit higher than a lot of studies. And you could be on psychostimulants during the study if you had been on a stable dose. And what you can see is in this study with hundreds of participants that there was no difference really between our study and this study, and that quetiapine was no more effective than placebo, and both quetiapine and placebo reduced CDRS scores. So what we were seeing is this large placebo effect similar to what's been seen in unipolar depression in children, but we're seeing it now in bipolar depression in both of these studies. But quetiapine was no more effective than placebo, and both were effective. Side effects are no big surprises with quetiapine, very similar to what was seen in the mania studies. Sedation, dizziness were the most common side effects. So the olanzapine-fluoxetine combination study is a study that was done in bipolar depressed children ages 10 to 17, and it was a fairly large study as well. And you can see here that there was a greater effect of the OFC versus placebo in reducing CDRS scores. And there was still a very large placebo effect, but OFC did beat placebo. And so these are the efficacy data that led to OFC getting approval for this indication. Side effects were pretty significant, and nothing unexpected necessarily with OFC, but significant appetite increase. There was sedation, tremor, and what was most significant, of course, was the metabolic side effects in this study. So weight gain was about 50% of patients in the short time frame gained significant amount of weight, and also fasting triglycerides and lipids were significantly increased in the OFC group versus the placebo group. So not particularly well tolerated. In general, the metabolic effects you heard from Dr. Robb about the metabolic effects of SGAs in particular, and younger children, as she mentioned, are more susceptible to the side effects of weight gain and other metabolic complications of SGAs. There are some medication strategies and behavioral strategies, lifestyle intervention, metformin, that may be effective at reducing some of these side effects. But until now, OFC is the only FDA-approved medication for bipolar depression. So if you're going to use something on label, it's important to know about strategies to potentially mitigate the metabolic side effects. So then lastly, I want to talk about a recent study of lorazepam for bipolar depression in children and adolescents. This study is a recent study to be completed. It is a study that was a 6-week study, double-blind, placebo-controlled. So lorazepam, which was flexibly titrated from between 20 milligrams and 80 milligrams per day. This study also has an extension to it of up to 2 years, and that study is actually still ongoing. And so we don't have the long-term results at this point yet. The study was about 300 participants, evenly randomized to lorazepam or placebo, very similar to what you'd expect in a bipolar depressed sample, pretty even in terms of gender. What you can see, though, is that very few participants discontinued during the course of the study, both in the placebo group and in the lurasidone group. And here you can see that starting at week 2 on the primary outcome measure, which was CDRS scores, there was significantly greater improvement in the lurasidone group versus the placebo group. The mean baseline CDRS score was, again, around 60. It was 59 in both groups. And so, again, a significantly depressed sample of bipolar depressed children and adolescents. The mean dose of the lurasidone was about 30 milligrams. So it wasn't a very high dose, even though there was flexible titration between 20 and 80 milligrams. And a secondary outcome measure that is the Clinical Global Impression Score, the depression severity score, you can see that, again, starting at week 2, there was significantly greater improvement in the lurasidone group versus the placebo group, and that significance was maintained until week 6, and the spread between the two groups increased over time. There were other secondary efficacy measures, such as anxiety scales, overall global functioning, and in both of those, there was significantly greater improvement in the lurasidone group versus the placebo group. The response definition, which is greater than or equal to 50% improvement in CDRS scores, was significantly greater in the lurasidone group versus placebo, with a number needed to treat of around 5, which means you treat 5 people, 1 person will get better significantly. The remission rates, with the definition of remission as listed, was not significantly different between lurasidone and placebo, although it was greater in the lurasidone group. Side effects. The most common side effects were nausea and sedation. There was some insomnia and complaints of weight increase, but what you can see is that actually when you look at body mass index, that in this short time frame of the study, there was no significantly different increase in lurasidone versus the placebo group. So at least in the short term, there seems to be some indication that it is not as metabolically adverse as some of the other SGAs. You can see that when we look at significant weight gain, or those who gain more than 7% of their baseline weight, it's actually lower in the lurasidone group versus the placebo group. So very low rates in both groups. So in terms of other safety measures, there was no difference in terms of extrapyramidal symptoms, no difference in other lipid profile measures, and there was some significant increase in prolactin in girls in particular, but it wasn't necessarily clinically meaningful, and it didn't lead to reported side effects. So, in conclusion, there have been very few controlled studies in pediatric bipolar depression. In children and adolescents, there's been basically the OFC study that has shown that the combination of olanzapine and fluoxetine reduces depressive symptoms more than placebo, and that led to the FDA approval. And now we have lurasidone, which is now the first monotherapy that has demonstrated efficacy for bipolar depression in children and adolescents. So with that, hopefully I got us back on time and didn't talk too fast for people. And thank you. And people are going around. If people have cards and want to ask questions, I'll invite Dr. Rob and Dr. Ting to come up.
The first question I got was, if one asks, one often finds an antecedent triggering event when developing bipolar disorder, how would you, our experts, differentiate between an acute stress reaction and a manic or hypomanic episode? Yeah, I get this question a lot about acute stress or PTSD or trauma. We know that trauma is very common in adults who have had bipolar disorder, they have very high rates of childhood trauma. And what I look at it as is that if you have a hypomanic or manic episode, you have a hypomanic or manic episode. It means that you meet the criteria, and that's what your reaction to stress is. As we know, most of these psychiatric disorders are combinations of stress and environment, in the environment and genetic loading. So it's just another stress. It shouldn't preclude your diagnosis. Now, it may have implications for treatment, right? So it may be that whatever that stressor should be removed or addressed in treatment, but it doesn't really change your diagnosis. So you should still approach it as a manic or hypomanic episode. There's no evidence showing that that makes it more treatable or less severe than any other manic episode that occurs with an unidentifiable stress. So that's my question.
Okay. I've got several, but I'm going to pick the easiest one, which is at what point in weight gain do you add metformin? In the clinical trial that we talked about, she actually did 2 trials. One was open label and one was this double-blind placebo-controlled trial. They waited until they'd gained more than 5 kilograms. But for most people, if there's a dramatic weight gain the first 4 weeks of treatment, they're going to continue gaining weight. And one of the things you can do is try switching early before the weight gain gets out of hand and you're up to 10 or 20 pounds. But I think if you've got somebody who's already starting out overweight, you might think about metformin earlier rather than later. Oh, I'll do one more, which is, have there been any studies in child and adolescent population with bupropion in bipolar 1 or 2 with comorbid ADHD? I'd be again concerned, even though there has been a study of bupropion in adults with bipolar depression, that it would promote cycling, and I would rather use a stimulant or guanfacine or long-acting guanfacine or long-acting clonidine to treat the ADHD, because that's not going to be as likely to make somebody more manic.
Okay,
Somebody else.
I'm going to try and get through some of these questions. So one question is, what effect does a mood stabilizer have in protecting against conversion to mania when an SSRI is added? We don't actually have controlled data to answer that question in children and adolescents. I can say that in the retrospective, I wonder if that's my phone, in the retrospective study that was done, that some of those kids were on mood stabilizers as well as SSRIs. And while it seems, again, to be one of the most effective treatments, it does not necessarily mean that being on a mood stabilizer, at least in that study, protected against having manic symptoms. And then related, the question was about in the lorazepam study, were these patients on mood stabilizers? No, it was monotherapy. Were they taking Ativan? And there was PRNs, but there was minimal PRN use in the study, and no difference really between the groups. And then the question about, did patients switch into mania? And in fact, there was significantly greater improvement in Young Mania Rating Scale scores in the lorazepam group. But again, these people had to have very low manic symptoms and YMRS scores to get into the study. So what that means, it doesn't cause people to switch into mania if it actually improves manic symptoms. A lot of times the young scores can be artificially inflated because of overlapping symptoms. But it didn't have significantly greater manic switches than placebo. Then another question is, in the lorazepam study, the baseline CDR-S score was about 60. The endpoint score was about 30 to 35. So how clinically significant was that effect? It was in the medium range if you looked at the effect size. So it is not small. It's not a large effect, but it is in the medium range. And I would say that, you know, a 25-point improvement in CDR-S score is pretty significant when you look at the symptoms. It's clinically meaningful. So, go ahead.
Oh, sure. I have a question. How do you differentiate between severe oppositional defiant disorder and milder DMDD? I look at oppositional defiant disorder is sort of a fever. It's a sign of an unhappy child. I rarely see it as a primary diagnosis. I usually look for the reasons underneath it, and most kids don't want to be completely oppositional and unhappy. It's usually a reaction to something. As far as how you differentiate between that and DMDD, that's a good question. I think that is a good possibility that in kids who have this chronic irritability, they may have a lot of ODD stuff going on. You may want to look to see what's making them unhappy. I think the bigger question is, what do you do about it, and what else can you look for? Because again, I don't see ODD as an endpoint. I see it as a symptom to look for underlying depression, underlying anxiety, underlying mania. So I would say do that instead of trying to differentiate between the two. Natalie?
And I have a fun question about Tourette's and bipolar disorder, and have I ever seen somebody with Tourette's and a family history of recurrent major depression that's bilateral? The patient's on guanfacine and sertraline, and what do you do, and what's the risk of bipolar? I think anybody that's got a bilateral family history of a mood disorder is at high risk for bipolar. And one of the things that is now used in a lot of clinical trials of Tourette's, besides checking for pandas, because you always want to worry about that, somebody with really bad tics, is the tick-focused cognitive behavioral therapy, and that's actually been manualized, and that would be another way that wouldn't increase the risk of bipolar because you wouldn't be giving them a lot of antidepressant to get those tics under better control. And of course, after you've used your alpha agonist, the next line in Tourette treatment is the atypical antipsychotics. And again, those are all FDA approved, or most of them are, for the treatment of bipolar disorder. So you would cover 2 illnesses with 1 medication, and that would be fine. And the last question was for me or Dr. Del Bello, but it was a comorbidity question, is for the olanzapine fluoxetine combo drug that has such a high rate of weight gain, would you use metformin to treat the weight gain associated? And I would say, again, yes, if the weight gain got up over 10 pounds. I want to say one funny story. In the olanzapine registration trial for bipolar, we had one kid on the 20 milligrams a day of olanzapine, and he didn't gain a pound, and that was because his father was a personal trainer and made him exercise 2 hours every day. So if you exercise enough, you can be on one of the higher weight gain antipsychotics and still not gain weight, as long as you don't eat uncontrollably. So you really have to control input and output, but it's possible.
How old was this kid?
This is a 17-year-old with schizophrenia.
17. Okay, 17, that's good.
And he didn't gain a pound, but his father worked him hard every day.
Great shape, though.
Yeah.
So, do you have any other?
No.
Okay. So one of the questions is, what is the recommended treatment if lorazepam poops out after 6 months? So I would start by asking if they're taking it with food. A lot of times, several months into treatment with lorazepam, the patient forgets that they need to take it with at least 350 calories for it to be absorbed. And most commonly, if it stops working, and it was working, that is what I've seen. And just reminding patients that it's very important to take it with 350 calories of food, any type of food, to increase absorption. That seems to help. Depending on the dose can be adjusted. If lorazepam, after you do those couple of things, just doesn't seem to be having the same effect, then potentially adding on a different medication, potentially, even though it's not on label, but another mood stabilizer might be a reasonable option. And eventually, if you need to add on, if they're more kind of chronically depressed, not acutely, something like lamotrigine may be a reasonable option, off-label, of course. And then another question is about using long-acting injectable antipsychotics for children and adolescents. And I do think more and more we're seeing them used for especially non-adherent children and adolescents, particularly adolescents and older adolescents, and particularly for manic episodes. So I don't think it's unreasonable. I don't know.
No, I mean, I used to run our inpatient services, and we'd have people that would do great in the hospital, taking their medicine. They'd go home, they'd fill the prescription and never swallow a pill and come back 2 weeks later. Those people started getting long-acting injectables before they walked out the door.
Right.
Yeah.
No, we have one more question.
I'm done.
I have one. As a great 15-year-old, this is a case study with 140 IQ, offered a scholarship from the most prestigious colleges, fell in love with a girl, and tried to commit suicide. Started smoking and using marijuana, saying it relaxes me. Question is diagnosis and treatment. Stay away from girls. Well, seriously, I mean, you know, one of the biggest stressors in adolescence are relationships. It's nonstop. And you know, my son says he doesn't want to have any relationships because he doesn't want to be stressed out. And I said, you know what? I think you've learned from your father. That's very No, it's one of the biggest stresses. We're cursed to be socialized animals, right? We need, most of us, not all. But you know, as a species, we need to be social, and it's also our biggest downfall. And I've learned over the years that your significant other is going to be your greatest stressor in your life, and your greatest support, supposedly. And I think that's really important to remember. But at the same time, this guy sounds like he has a lot of anxiety. So because he's smoking, like if he's smoking cigarettes and he's using marijuana, saying relaxes, I'd look for underlying anxiety and treat that. 140 IQ. Wow.
Yeah, pretty smart.
That's really good. Yeah.
Okay. Well, I think with that, we will end. And thank everyone for attending this morning. Thank you.
Thank you very much.
This concludes our program. Participants should complete the post-test and evaluation to receive continuing education credit. Thank you for your participation in this activity.